Okay, welcome back, and thanks for coming back into the room so punctually. And so we're going to get ready for the second session of the morning. So this follows on really well from the session preceding, where we touched on the issues around cognitive impairment. And now we're going to hear from two researchers that have been doing some large-scale work and trying to do research with some of the most vulnerable patients we see with hip fractures. So looking forward to hearing their experiences. Before I do, I don't want to forget, is there a Promic here? It's probably pronounced not very well. Promic? Okay, I'll just be over in a sec. Okay, so without further ado, I'd just like to introduce Maggie Killington from Flinders University, who's going to present her work. And then we'll hear from Lauren Brubery after that. So thanks very much.
Thank you very much. Well, I think it's really exciting to be here, and I must say the first presentations this morning really led beautifully into the work that Lauren and myself are going to talk about. So what we're wanting to know is, should we provide outreach rehabilitation to very old people living in nursing care facilities, and in particular people who've had a hip fracture? I think the myth in Australia, anyway, where I'm from, is that, you know, if you have a hip fracture, you're very old, you're in a nursing care facility, it's really the end of the road. And I think that myth is perpetuated constantly. And then, of course, what happens is, if you don't believe that you can make a difference, it's like a self-fulfilling prophecy, isn't it? You don't provide intervention, and therefore you don't get better. So what we're wanting to know, so we have undertaken an RCT, and what we wanted to know is, when mobile older people from nursing homes fracture their hips, will a 4-week outreach rehabilitation program into the nursing home with a geriatric, ortho-geriatric approach make a difference? Will they learn to be, will they become mobile again? Will the effects persist? And also, is it worth the investment from a financial and societal perspective? So what we did was, we undertook a single-blind randomised controlled trial. We enrolled 240 people from 76 different nursing homes. We had 119 people enrolled into the intervention and 121 into the usual care. We randomly allocated the participants prior to them leaving hospital, and then we provided 4 weeks of intervention. Within 24 hours of the resident going back to the nursing home, and also a geriatric registrar went and did an assessment, a medical assessment. The physiotherapist went into the nursing home within 24 hours to 48 hours, if it was a weekend, but we tried to still provide these interventions early. And also a dietitian also came in and provided a dietetic review and therapy. So we looked at our primary outcomes at baseline prior to them leaving hospital. We then we assessed them again at 4 weeks, and then again at 12 months. 12 months was really related to the health economics assessment, really. So the outcomes that we undertook were, our primary outcomes were mobility, and we used the nursing home life space diameter, which is a measure of how far people venture from their bed, and then venture out from their room, out into the nursing home, out onto the veranda, and also it looks at how much assistance they require to do that. We also looked at quality of life, in particular the DENQUAL and DENQUAL proxy. Out of our 240 participants, only 3 people could actually provide their own consent. So they had severe dementia, the majority of our people. We actually undertook a number of secondary outcomes as well. We looked at adverse events, and also we did a qualitative study as well, which I'll talk about briefly. So who were the participants? Well, they were older people. They had a mean age of 88. They were mainly female, and they had a mini mental of 8 out of 30. So we really are talking about people with quite marked dementia. They could all walk prior to their fracture, some of them not very far. And all of them, well, 88% of them had surgery within the 24 hours. So they were managed quite quickly in the acute setting. What did our rehabilitation program look like? Well, as I say, they received the medical input, but the physiotherapy consisted of approximately, we had the mean number of visits of just under 14 in the 4 weeks, and that looked like about 12 hours of physiotherapy. And we were really happy that even though we had people who had marked dementia, basically they didn't miss many sessions. We had quite a high adherence rate. And I think that was because really of the approach of the therapist and the rehab team, who had to be quite innovative and flexible. So what did the physiotherapy look like? Well, I think we all know that there really are no clinical guidelines to guide us when we're looking at people with dementia, with this level of dementia in nursing care facilities. So what we did was we went to all the latest guidelines and tried as best we could to provide best practice that had been published for people in the community without dementia. So I think the interesting thing here is that what you'll see is that the things that we very much would have liked to have done, protocolized physiotherapy like the Targo balance exercises and resistance exercises, it was difficult because people could not use their explicit memory system. They had marked dementia, they had difficulty communicating with us, and so we actually had to be quite inventive and try and find ways of challenging them that were outside some of the protocolized interventions that have been published. So as you can see, we did do some resistance exercises as shown to be important in this group, but that actually, a lot of that was shaping. They might have some weights and we would shape the activity with them when we could, but only 37% of people could do that. So what did usual care look like? Well, it was a depressing situation, I might tell you. Usual care was not something to be proud of, I don't think. Basically, out of the people in usual care, which is 121 people, they had a median of 6 sessions of physiotherapy in the 4 weeks following their return to the nursing home, and they were provided just under 2 hours of physiotherapy after a very major incident and a huge operation. You'll probably note that our in-reach rehabilitation team received very little, although they were asked to provide the usual care that they would normally get. But I guess what happened was we came in, we took over some of the care, and I think the therapists were just delighted that there was someone else there, and I think they then directed their care somewhere else. It wasn't what we asked them to do, but it's certainly what happened. So how did the physiotherapists engage these patients with dementia? Well, we were dealing with lack of motivation, ambivalence and resistance. And so what we did was we actually developed a very person-centred approach. We spent time with the family and the carers to try and understand who this person was, what were their values, what were things that were important to them. Obviously, pain management was a huge target and focus of our approach, where we worked with the doctors who actually reviewed the medications, and we ensured that we saw these people at their best time of the day, if we could possibly do it, and that they would have had their pain medication about 45 minutes to an hour before, depending on the individual's requirements. Because we know, and Abby told us earlier, and we need to develop goals. Rehabilitation is about setting goals. So we actually use motivational interviewing in a very adaptive way, but we did use it to try and actually encourage the resident to develop some goals that were important to them. We used identity remapping. We used a number of techniques that have been shown to work in people with brain injury, and a number of us were neurophysiotherapists. We had brain injury background, so we actually brought some of that knowledge into this trial. I realised very early on that these people had a neurological impairment, a dementia, as well as a fractured hip, and probably the fractured hip was probably the least of our worries at many times. We used errorless learning. So the day after we'd seen them the day before, we wouldn't sort of test them. Do you remember what you did yesterday? Do you remember that we did this? No, what we'd say is yesterday we did this, and now we're going to do this again today. So what were the outcomes? Well, mobility we unfortunately had the very situation in the acute care where our patients were really neglected in acute care. People felt in acute care that they have dementia, and therefore they're not going to be receptive to rehabilitation. So not one of our participants had left their bedside prior to going home. At 4 weeks, the intervention did show a statistically significant improvement, but unfortunately at 12 months, so 11 months after we left the facility, the outcomes were the same as usual care. Deaths, this was quite shocking. We felt that in the control group, the deaths increased each week after discharge. So there was a real pattern to the way the deaths occurred in the control group. Certainly we had deaths, of course we had deaths in the intervention, but there was no pattern to the change. And certainly there was a statistically significant increase in deaths in the control group. So the economic evaluation, at 4 weeks, we thought we might have a chance of it being cost effective. We had improvements in mobility, some very small improvements in quality of life. But then when we got to 12 months, we still had a slightly higher quality of life per patient, but there was certainly not a good case for funding if we look at a traditional health economic perspective. So then we did a qualitative study. This has been published, The Chaotic Journey Recovering from Hip Fracture in a Nursing Home. We invited the first 30 people who were randomised into the trial. We talked to family and we talked to nursing home staff. So we interviewed 25 family, we interviewed 28 nursing home staff in focus groups, and it was fairly well divided between intervention and usual care. So what were the results of the thematic analysis? Well, it was a chaotic journey, recovering from hip fracture in a nursing home. They had a very poor start. People weren't managing the dementia in hospital. They were sent back into the nursing home often very quickly. But the problem is when they got back to the nursing home, no one in the nursing home knew how to manage a hip fracture. So it was a torturous journey from beginning to end for those in usual care. The nursing home staff lacked confidence about, how do I move this person? Should I move this person? And there were certainly poor patient outcomes and a loss of hope for the patient and their family. In fact, many of the families reported that they needed to spend most of the day with their loved one because they were so anxious and frantic and really just devastated by their situation. Fortunately, the responses and the reports of people who received the in-reach rehabilitation was very different. They felt very positive. I think people's improvements exceeded their expectations because of this myth that everything would go downhill very badly. They were actually quite shocked to see that, they were getting up and at it. They were actually, some people saying how, they walked down to the nurse's station to get something, etc., etc. So they were actually quite shocked by it. They had increased self-confidence. They were mobilised early. The geriatric input was very, very much valued by the families and the nursing staff because the geriatrician managed the pain and looked at all the comorbidities, and really they valued that very much. And also their nutritional status. In fact, out of all the secondary outcomes, that was the only one where we actually had a statistically significant improvement at 4 weeks, and it was not far off it was certainly close to at 12 months. So the dietetic input seemed to be very, very important. Many of them lost about 4 kilograms of weight in that short stay in hospital, and most of the people in the intervention did put most of that weight on within the 4 weeks. So that was very encouraging. So what are the key points? So a 4-week multidisciplinary post-operative rehab program after hip fracture was associated with better mobility and survival at 4 weeks compared with usual care. But the benefits didn't persist, unfortunately, when we left. Only a small gain in quality of life at 12 months, we found. It couldn't obviously be considered cost effective against current funding therapy thresholds. However, We did undertake a citizens' jury sometime after the trial had completed, and the citizens' jury supported the fact that, yes, we should be providing this sort of intervention. And we felt that future trials should explore different approaches to post-operative hip fracture recovery. And we particularly felt that we were the visitors in the nursing care facilities. We went in there, we wanted to work with the people in the care facilities, but in fact, it just really didn't happen very often. So we came in and did our rehabilitation and didn't really work terribly much with the nursing home staff. We felt that if we could have actually developed a collaboration and if they actually really believed, if we could actually help them believe that yes, you can make a difference, if you actually provide good care, a restorative approach, a rehabilitation approach, that you probably could make a difference. So what we did was next, and I'm not going to play these videos now because I'm really looking forward to hearing from Lauren, but basically we developed some resources, and these resources are videos that we developed really for nursing care staff in nursing care facilities, and we'll be playing one of those messages at the beginning of the discussion just to give you a sense of what we were trying to do. So we're trying to let nursing care facilities staff know you can make a difference. You need to get together, you need to set some goals, you need to manage pain, you need to get people up and at it. You can make a difference. So that is the message from some of these resources. Thank you.
Okay, thanks very much.